reduction, fewer side effects? Is it visual field preservation, or is it the cost of the therapy? Well, now the new standard in glaucoma care is preservation of visual field while also taking into account the standard of living of the patient at a sustainable cost. So 6 questions to ask yourself before starting treatment. What is the goal of your treatment? What are your treatment options? What are the side effects? Why are these slides going on themselves?
I think you've not set the timer. नहीं, in her presentation she's not rehearsed timings. No, ma'am. In her
अपने आप
PowerPoint
आगे बढ़ रहा है स्लाइड क्यों?
अपने आप चल रहा है
slide show कर
वो.
दिया.
Rehearsed timings she's not removed. Good, Satinder?
You must have pressed that slide show.
No.
नहीं. Rehearsed timings का option ना, she's not removed that from the PowerPoint. We just started.
For every glaucoma patient is very individualized. Studies have time and again suggested that IOP reduction has shown to reduce the progression of glaucoma, but the challenge is to identifying the patients at risk, and sadly IOP is the only modifiable risk factor we have at hand that we can treat. Now something's wrong, now the slide is not moving. Okay, so according to me, there are 3 categories of glaucoma patients: those who will do well no matter what, those who will do poorly no matter what. But the biggest challenge is identifying the category of patients, those whose long-term outcomes may depend on your management choices. So make sure that you formulate a target IOP very carefully in these patients. You might have to have a lower target IOP in patients who present to you with advanced glaucoma with high risk factors, where IOP untreated is low to begin with, where patients who are fast progressors, and also patients who have long life expectancy. So this is something very interesting that came about. So OHTS actually has a software out there which can calculate your glaucoma suspect patients and their and it can estimate the 5-year risk factor for developing POAG in these patients if you give them a few baseline data material. So always before starting therapy, try and take several IOP readings. There's usually no need to start treatment unless all baseline diagnostic tests are available, unless of course the IOP is very high and there is significant damage. Take a good medical and ocular history, grade the severity of glaucoma. Now clinically applicable target IOP can be set at a range of 15 to 17 if your patient has early glaucoma, 12 to 15 millimeters if the patient has moderate, and 10 to 12 millimeters of mercury if the patient has severe glaucoma. And in choosing your appropriate medication, the most important factors are to be considered are cost effectiveness and minimum dosage, because this is what is going to decide the compliance from the patient. And again, this is just a fun fact, no take home messages from this. This is just an article which actually states that there are 56,000 ways of treating glaucoma. So now with so many treatment options, don't get lost. Remember the rule of thumb that there should be a 20% reduction in mild cases, 30% in moderate, and 40% in severe cases. Always start with a monotherapy. There are 6 classes of anti-glaucoma drugs that are available to us, and newly in the Indian market, tafloprost, which is the newest PG analog, has been introduced only in 2019. So this is a meta-analysis of RCTs which is comparing the IOP lowering effects of different medications, which says prostaglandin tops the list, followed by non-selective beta blockers, followed by alpha adrenergic agonists, selective beta blockers, and then topical carbonic anhydrase inhibitors. Now your first drug of choice for a POAG or an ocular hypertensive or even an angle closure disease post laser peripheral iridotomy can be prostaglandin analogs for 2 reasons. Why? Because it's got the maximum IOP lowering effect and also once a day dosage, which improves compliance. It lacks systemic side effects, and also number of latanoprost generic drops are available now, and preservative-free formulations are available which are safe for your patient. Now, out of all the PG analogs, bimatoprost proves to be the one which has a maximum IOP lowering effect, but also has a maximum side effects. But truth be told, the difference amongst classes within, difference amongst all of these drugs within the PG analog class will only differ in their ability to reduce IOP by, say, maximum about 1 millimeter of mercury. Always remember that poor responders to one PGA might respond to another PGA. So switch within the same class before you switch the class itself. If you need about 20% reduction, beta blockers are your treatment of choice, and efficacy of these drugs will reduce if the patient is already on systemic beta blockers. tell the patients about the correct dosage, also mention the side effects to your patient, otherwise when they develop these, they'll come back and catch your neck. Now, if you need more than a 40% reduction, combination therapy is your way to go, because no single drug can reduce the IOP lower than 40%. However, don't start with the combination therapy, except of course the patient has advanced glaucoma, very, very high IOP. The trick over here is that the time interval between therapeutic incremental steps can be decreased. Combination therapy, of course, is superior to polydrug regimens in the fact that cost is lower, there wouldn't be adherence issues, there will probably not be washout of earlier medications, and also decreased exposure to preservatives. Now, this is just a case of POAG, 4 years old, on PG analogs with a pressure of 17 and 18, open angles. This is the visual field over 4 years, progressing in the right eye, significantly progressing in the left eye. This is what the optic disc looks like. Now, this patient responded well to initial monotherapy. However, the visual field was progressing in spite of a 25 to 35% reduction in IOP. SLT may not work in these patients, remember, because he's already using PGA for 4 years. Now, better option is to add a medication. Now, the question arises whether it should be a fixed combination or a single agent. Well, that depends on what your final target IOP needs to be. Now, the treatment options that I had at hand from this case was either switching the PG analog to a fixed combination of PGA and a beta blocker, or add a beta blocker over and above the PG analog, or used a fixed combination over and above the PG analog that the patient was already using. But always remember that addition of a single agent to a PG analog is unlikely to lower the IOP more than 3 to 4 millimeters of mercury. There are various fixed combinations that are available in the market. Now, the question arises when to switch and when to add. So, when you always start with monotherapy and that's being tolerated very well, and it's affecting on lowering the IOP, but the target IOP is not reached, in that case add a second drop. Even if the target IOP is not reached, even after that, try to rule out compliance issues. But in the first place, if the monotherapy is not tolerated very well, or the IOP is not being reduced to the amount that it's supposed to, switch the monotherapy. So, in this patient, we added dorzolamide twice a day to a PG analog. The IOP reduced to 12 both eyes, and the visual fields remained stable since then. Now, there's also an article quoting that carbonic anhydrase inhibitors are best adjuncts to PG analogs in lowering the IOP. So, you might have situations where there's progression only in one eye, but make sure not to give too many confusing regimens to your patient, maximum of 2 bottles and 4 agents. So, these are just a few pointers to improve compliance with your patient. This is an Ethiopian patient that came to us, and on being asked to demonstrate how he puts his drops, he was literally scrubbing his ocular surface with the tip of the bottle. So, make sure you're giving them enough information, spending time with them, and also praise the lowering of IOP that he has achieved with his efforts every time he comes to your OPD. And there's a lot of promising the future of medical glaucoma is very promising, and we're waiting for it to enter the market. Thank you so much.
Thank you, Dr. Sethi. And as she very rightly said, there is no fixed number for target IOP like 18. It depends on.
So, glaucoma management is more of an art than a science. The introduction of several new classes of glaucoma medication and the completion of many large randomized clinical trials have not changed this fact, and while we now have a better choices when initiating the glaucoma therapy relative to our preceders, the principle of glaucoma therapy have not yet changed. The reduction in rate of ganglion cell or delaying the progression of the visual field is the aim of glaucoma treatment, and we also have to maintain the quality of life. We know that the retinal ganglion cell loss is age related, and this loss is 10 times greater in the glaucomatous eyes compared to the normal, and what we have to do is to bring up the line which is going down by treating these patients. The various studies, particularly AG study, has demonstrated that lowering the intraocular pressure is associated with the reduction in the progression of visual field defect, and the field loss was lowest when the patient was followed up with the IOP below 18 millimeter at 100% of the visits, or the mean IOP was 12. And so did the old study has said that by lowering the intraocular pressure, conversion rate to the glaucoma is lower. So the lowering is intraocular pressure is the only option available to us, and how low is the better? Dr. Narang said that it could be even lower. So that brings the concept of target intraocular pressure, which is a personalized, customized, or and a dynamic thing. It prevents the IOP, which prevents the further loss without losing the quality of life, is the target pressure that we have to. It's not a magic number 1 or 20 or 18, but it's a range, and it is already been discussed by previous speaker how we decide on what should be the target range. Other consideration for that is not only the severity of the disease but comorbidity, what is the life expectancy of this patient, and most importantly family history and the cost and risk factors involved. Lowering IOP lowering with monotherapy is ideal treatment. However, it may not be enough in all the patients because of maybe a patient is non-compliant, there is a risk of adverse event, and the Coates collaborative initial glaucoma treatment study has shown that at the end of 2 years, 75% or more patients require 2 drugs or more medications. Same is with the O study. So we know that monotherapy is not enough for many patients over a period of time. So what should be the appropriate action of the patients who did not respond adequately to the monotherapy? Should we switch to the another molecule or to add another IOP lowering medication? So according to EGS guideline, if first choice monotherapy is ineffective in lowering intraocular pressure less than 15% from the baseline or is not well tolerated, you have to switch. If first choice monotherapy is partially effective or efficacy is more than 15% in lowering IOP but does not achieve the target pressure, you add one more medication. Now how do we select a second therapy? It depends upon the primary therapy that patient is using, and most of the patients nowadays we are putting them on PG analog or beta blocker. So once you have achieved the IOP reduction that you have expected from the primary agent, if you have not achieved, there is no point in switching to the same group of or same class of the drug and try to another agent from a different class of the drug. This is a classic example of a mild primary open angle glaucoma. IOP, baseline IOP was 20 and 21, and we selected to use beta blocker in this particular patient. After 1 month follow-up, the right eye pressure was 19 and left eye was 20. So the reduction of 15% is not there. So this drug is either not effective or there is a poor compliance. So what should we switch to? So the 3 molecules that are shown here, I prefer to use PG analog because this patient had a very low IOP to start with, 20 and 21, and PG analog can lower with a good compliance, once a day dose, less systemic side effect, and it can lower the IOP below episcleral venous plexus. Another example of angle closure glaucoma with a bronchial asthma, and this patient was started on pilocarpine till we did the YAG-PI, and we continue the pilocarpine subsequently, and the gonioscopy showed opening up of the angle. The target IOP was achieved, but here the problem was that with the discomfort and the headache with the pilocarpine. So she wanted to change the medication. So we need to switch the drug. So this is the beta blocker is out of question as patient has a bronchial asthma, known case, and these are the drugs that one can choose to. So when the monotherapy initially is achieved the IOP reduction you expected but does not bring the patient to target pressure, the best option is to select another group of drug, and it depends on what is the first drug that is already been chosen depending upon the safety, efficacy, convenience, tolerability. This all is applicable when you want to add the second molecule. Select the one which is most likely to lower IOP to the target range and choose the cheaper and better tolerated agent according to the patient needs. Now this is a very important pearl that efficacy of the same molecule as adjunct is different than when it is used as a monotherapy. For example, beta blocker as a monotherapy lowers IOP by 5 to 6 millimeter of mercury, but when it is added to PG analog as a adjunct, the supplementary reduction is only 1 to 2 millimeter of mercury. We have to also see that the patient is Remember, patient is asymptomatic till we start the treatment. So we have to select something which has a less side effects, convenient dosing, good bottle quality, and of course we have to think about the cost of the drug. And what to select? Always select the complementary mechanism of the two molecules that you have, and the fixed drug combination is a better options. Now, preferred agent as a primary therapy, as I said initially, is a PG analog in most of the cases, unless it is contraindicated, because it is good as a lowering the intraocular pressure. Efficacy is about 25 to 30%. It also has a diurnal and nocturnal IOP lowering effect, and it lasts beyond even 24 hours and well tolerated systemically. Now, usually the beta blocker is added to all the combinations, but it is not necessarily the best adjunctive agent when used in patients already using the PG analog. The topical carbonic anhydrase inhibitor various trial has shown that has a beneficial adjunctive effect to the PG analog. So choose the agent depends on this as I have said, various factors. So to conclude, there is no one size fit all algorithm. You have to customize the treatment according to your patient's need. Remember, IOP lowering must follow 24-hour circadian rhythm, and also look at the comorbidity that patient has. Selection is incomplete until you have performed a therapeutic trial in your patient.
Thank you, ma'am. Thank you. Always finishing in time. Dr. Gursatinder is Bansal, then Akriti.
Should I?
Yeah, please.
Ever-rising demand of glaucoma management results in a constant search of an avenue to improve upon existing treatment management and innovative newer options. So today I am going to talk on what are the newer horizons that we have seen during this time. The sustained release implants in the retinal diseases have been causing ripples since its inception, and will such modality bring shift paradigm in the glaucoma management, that we are going to talk on this to share this what is brewing in the glaucoma management in this regard. After 20 years, we are now going to have two new class of drugs which are approved by US FDA this year. The Netrosudil 0.02% and latanoprost budon 0.024% have a novel approach in the IOP reduction. The Netrosudil is a ROCK inhibitor shown to reduce cellular stiffness. It is also norepinephrine transport inhibitor. It facilitates the trabecular and uvoscleral outflow. The dose once a day is as effective as the timolol BID dose and has no contraindication like timolol. The latanoprostone budon enhances the uvoscleral outflow, and it is a nitric oxide which dilates the blood vessels, and that improves the microcirculation. Now these both molecule has an additional distinctive feature. It can give a neuroprotective action. So maybe it has a significant role when we are considering the normal tension glaucoma patients. So whatever said and done, the need for the prolonged treatment or chronicity of this disease burden with its cost entails us to search for the alternative modality of the treatment, and we have to bridge the gap between the drug non-compliance and invasive surgery. So sustained release implants in retina, as I have shared, have already been causing ripples since its inception. So so many routes are shown in this figure. So are we able to find out a route for our glaucoma medication deposition? So new delivery systems are in the form of punctal plug, rings to be inserted around the globe that are also available. The timolol sustained release, a topical ophthalmic drug delivery system TOD, is placed under the upper lid, which works for 3 months, and latanoprost soaked contact lenses is another way to deliver the drug for a longer period. Now the latanoprost in a large unilamellar vesicle is derived from the liposomes, and it is given as a subconjunctival injection, which the effect lasts for 50 days, and this provides us a very good external platforms. The another is Duracet latanoprost injections, and that also works over a longer period of time. Now what about the internal platform? The myotoprost sustained release implants people are working on, and I think the phase 3 trial is been completed to be implanted into the antechamber, and it reduces the intraocular pressure by 6 to 8 millimeter of mercury and works for the 6 months. Similarly, travoprost is also to be implanted as an extended release biodegradable polymer, which reduce 30% reduction of intraocular pressure over a 8 months period. So it's a drug which is, these are the drugs which are going to work for a longer period, so that we can avoid the compliance issue. The ophthalmic micropumps are implanted over the sclera. They are wireless and they are programmable, and we can also use it again. It's a refillable. So it dispenses the nanoliter size doses, and this implant effectivity lasts up to 12 months. Now the decade have been elapsed since the pilocarpine sustained release approval, yet journey has not been completed. We are still in a very slow pace on the completion of this because of the challenges like backpacking of the drug solubility, and the time release versus therapeutic effect. So the looking at the alternative strategy to combat the aforementioned issues. Now we are knowing that in India now we have a Cyclo G6 is also available, and it uses 810 nanometer continuous wave diode laser. Micropulse P3 probe and G probe are available for refractive glaucoma. P3 probe is to be used for primary open angle glaucoma patients. 200 milliwatt of diode laser energy is delivered over 100 seconds within 0.5 milliseconds on and 1.5 milliseconds off, and it delivers 1.1% duty cycle. Basically, it is a continuous wave chopped into a short pulse duration, which is less than thermal relaxation time. So there is no tissue damage. It is spared and can be done repeatedly and induces beneficial biological factors. It is a non-incisional procedure, induces minimal inflammation with excellent safety profile, and can be used in a OPD procedure, and it gives us predictable results over a long-term period. This is how it has been done. The clockwise and anti-clockwise cycle has been done, and what it does, it works by widening the extracellular space, same as PG analog, and the probe is placed on the pars plana region 1 millimeter away from the limbus and moved first in clockwise manner and then backwards in 180 degree, and avoid the 9 o'clock and 3 o'clock position. So now it is time for a minimal invasion. Everyone is talking bad about the trabeculectomy or a filtering surgery, so I will be talking little bit on MIGS. I will not go into the detail, as there is some another speaker who is going to cover on MIGS. It's a minimally invasive glaucoma surgery and brings revolutionary approach to the target patients of mild to moderate glaucoma, and it has a very high safety profile. And it can be done ab interno or it can be done ab externo, and it preserves the important eye tissue for the future treatment option if this fails. And there are two options, external filtration or internal filtration. I will not go into the detail of this to save the time, and these are the options available. And the MIGS trabectom is now available in India, is FDA approved, Indian government also, and iStent is also available in Western world. And now Zen implant is going to come, and CyPass microstent is not been used. I will not go into the detail if she is going to cover on the trabectom, which ablates and removes the trabecular meshwork and unroofing of the SEMS canal. And it has a tip bend 90 degree to create the triangular protective footplate, which acts as a guide as well as it guides into the SLAMS canal. iStent is the smallest implant known to the body, and it has a 3 ridges which fix it into the SLAMS canal. It is heparin coated to promote the self-priming, and it should be used as a combined surgery with the phaco surgery. And it gives, see what is the problem in the open angle glaucoma, even the juxtacanalicular tissue is affected. So just by putting something there will not work, while this iStent will bypass this and gives us outflow facility, and the results are shown in this slide. And then stent is a flexible tube and should be implanted subconjunctively to avoid the, okay, only last 2 slides. Can I continue? The CyPass is a supraciliary tube designed to create a control outflow facility, and the Hydrous is a long tube and it's supposed to give a better results. So what are the experimental options that we have these days? As I said, various implants to be put into the supraciliary region, or the nanoparticle or a different delivery systems and injections, and the biodegradable implant to be implanted subconjunctivally. But
Ma'am,
I should not forget about the artificial eyes, which is very, very important in diagnostic as well as monitoring of these patients. Thank you very much.
Thank you, ma'am. Covering
Thank-
two. Yeah. Go ahead.
Yeah, first and foremost, I would like to thank Dr. Mayuri ma'am.
Good afternoon, everyone. My topic is effect of blue light spectrum of digital devices on vision among adults between 25 to 45 years of age. Now, use of digital devices like smart televisions, mobile phone, laptops, video games and tablets is growing tremendously. Most of these devices are LED based, emitting light rich in blue spectrum of light, and blue spectrum is falls in short wavelength of 400-500 nanometers, as we know, and is considered as the most harmful component of the visible light. It has the ability to pass through the cornea and could be absorbed by the iris or the pupil. The high energy short wave blue light, having wavelength in the range of 450 to 455 nanometers, has the ability to directly penetrate into the retina and is known to cause irreversible photochemical retinal damage. The digital devices are used both at workplace as well as during leisure, and as per the recent report, average Indian adult spend nearly 4 hours per day on digital devices and media. In view of the reported effect of the blue light spectrum of digital devices on the eye, this study was carried out to know the effect of vision on vision and intraocular pressure of adults. Now, the main aim of this study to know the pattern of LED based digital devices use, and to know the prevalence of significant users of LED based devices, and to compare the ocular symptoms and visual acuity, intraocular pressure among adults having significant exposure to these devices. The study was done at Sumitra Eye Care and Maternity Hospital, Lucknow, among the population of 25 to 45 years of age. This was a cross-sectional exploratory study over a period of 2 years, and with a sample size of approximately 2100. These were subjects with no previous history of refractive error, and presented with complaints of ocular complaints like headache, pain, burning eyes and eye fatigue. The subjects with known hypertension and diabetes were excluded, and vision less than 6/9 were also excluded. At enrollment, the demographic details and the presenting complaints of the patients were noted. The patients were inquired about the use of devices, and especially the night time uses were also considered. The intraocular pressure was measured using applanation and rebound tonometer. The screening was done at a 6-meter distance on a Snell's chart. The data was analyzed using statistical package of social sciences, a chi-square test, and these were the results of different age and gender profile. I don't want to go into the details of the tables. These were the presenting complaints of the different patients: the headache, pain, burning eyes, eye fatigue, and asymptomatic. A few were asymptomatic also. These were the device use pattern, like mobile users, computer users, or non-users, and the nighttime users of mobile and computers were also inquired. And these were the vision and intraocular pressure chart. I'll discuss in the discussion part. Pattern of mobile and laptop use of and its association with demographic and clinical profile of a study population, like age sex ratio, the headache, pain, burning eyes, and the tiredness or eye fatigue. This is the pattern of mobile laptop use and its association with best corrected visual acuity. And this is the pattern of mobile use and its relation with intraocular pressure. Now, this is the comparison of mean intraocular pressure between mobile laptop users and non-users. And this is the influence of type of digital devices used on intraocular pressure, like mobile computers, and both mobile and computers, and neither of two. This is the influence of time of digital devices used on intraocular pressure, and this is the effect of age and gender on intraocular pressure. This is the multivariate assessment depending on the intraocular pressure. Now, the present study showed a high proportion of adult regularly using digital devices for substantial period of time. This finding is in agreement with the observation made by several surveys in India and abroad. In present study, the blue light spectrum exposure was not found to be significantly associated with best corrected visual acuity. However, intraocular pressure of the patients having blue light spectrum exposure was significantly higher as compared to non-users, and moreover, nighttime use was also significantly associated with increased intraocular pressure. Moreover, ocular symptoms were also found to be significantly associated with digital device use. The findings in present study are in agreement with the observations of Santa Kumari et al., who also observed that computer exposure is associated with vision-related problems. Other studies have shown that blue light spectrum exposure has deleterious effect on cornea, iris, and retina. The increased intraocular pressure in blue light spectrum exposed patients was indicative of long-term complications such as cataract, retinopathy, and glaucoma. A total of 58% patients approximately were reported to have a history of significant digital device use. The nighttime use were also reported by 21% patients, and among these devices, use of mobile phone reported in 38%, and rest were also of computer and the combined use. The majority of patients had best corrected visual acuity or 6/6 or 6/9 range, followed by 6/12 to 6/18. Digital devices use was significantly associated with younger age, that is 25-35 years, and male sex. The significantly higher proportion of digital devices users had complaints like headache, pain in eyes, tiredness, that is the eye fatigue or burning eyes. Use of these devices were also significantly associated with multiple complaint at presentation. Now, no significant association was observed between the best corrected visual acuity and digital device use. However, higher intraocular pressure was associated with digital devices use. The intraocular pressure of both day and night devices user was significantly higher than that of the only daytime users and non-users. The older age and female sex was significantly associated with increased intraocular pressure. The multivariate analysis showed that intraocular pressure of patients was dependent on age, gender, time, and exposure in digital devices use. Now, we recommend that technological advancement to limit the blue light emission in digital devices should be done. The protective eyewear should be used, and an alternative to LED should be discovered. According to American Academy of Pediatrics also, they showed that under age of 2 should not be exposed to any screen time, although this is a different this thing. Now, the take-home message is awareness should be created regarding effect of digital devices use, especially nighttime uses on vision. All the patients, especially of this age group, should be asked about their digital device use, and if they can frequently for the change of glasses or show frequent intraocular pressure variation without any specific reason. These are my references.
Thank you, sir. Thank you for finishing in time. Different talk, and we can have the discussion later, sir. Okay. Thank you so much.
Good afternoon. Thank you very much for the opportunity to present. So today we'll be talking on minimally invasive glaucoma surgery, or MIGS. No financial disclosures. So there are a number of different MIGS options that are currently available in the United States and in Europe. I understand that their introduction, as Dr. Mayuri pointed out, is also happening in India with the Stent and the trabectome coming over. So some of the things that we're going to be talking about today are conventional outflow devices that go into Schlemm's canal, as well as bypass devices such as mainly subconjunctival devices. So the advent of the Stent was pretty revolutionary as it kind of was the first device in the minimally invasive glaucoma surgery space. Since the Stent Inject has also come out, the Hydrous microstent has also come out. The Zen is a subconjunctival device, and the PreserFlow device is another device that's kind of in the pipeline and will be introduced sometime within the coming year in the United States. So first, let's talk about the Hydrous microstent. This is a flexible, biocompatible 8 millimeter in length microstent. It's made of nitinol, which is a highly biocompatible material that's used in cardiovascular stents. There's some question of whether or not patients with nickel allergy shouldn't get this device. There haven't really been any cases reported of this quite yet, but it has sparked some discussion. This device is contoured to match the canal curvature, so you can easily see that it's curved and kind of matches Schlemm's canal. It has 3 open windows that face the anterior chamber, which you can see with the red arrows. And the canal-facing surface of this device is completely open for collector channel access. So the entire back side of the device is open to the collector channels. So next we have a video. Not sure if this is going to work, but video here. Great. So we can see here the stent going into Schlemm's canal. You can see the 3 windows within Schlemm's canal of the stent. And because it is a rather large device, 8 millimeters in length, we can have confidence that it is accessing the collector channels, whereas some of the smaller devices like iStent, sometimes we're not quite sure if we've accessed the collector channels. So here you can see on gonioscopy the 3 windows of the Hydrous device. So some of the pivotal studies regarding this device, the first one was the Horizon study. The objective of this study was to compare Hydrous plus cataract extraction versus cataract extraction alone. 556 patients were involved. There was a randomization to Hydrous plus cataract extraction versus cataract extraction alone. There's a medication washout period. The primary endpoint in the study was unmedicated IOP. Secondary endpoint was a medication-free state. And there were no serious adverse events that were found in this study. We'll dive into the data a little bit deeper. So in the primary endpoint, 20% or more IOP reduction at 24 months, there was quite a bit of a difference that was noted at 19.5% in the Hydrous plus microstent group, Hydrous plus cataract surgery group versus the cataract surgery group alone. And you'll see here that at 1 year there was a 16% difference that actually grew to a almost 20% difference at 2 years. So the device seems to be equally effective over time, and whereas cataract surgery's IOP lowering effect may be kind of less effective over time, Hydrous kind of maintains good IOP lowering effect even at the 2-year state. The second endpoint was medication-free state, and we can see at the 2-year time point there was a 30% difference among those who underwent cataract surgery alone versus those who also had the Hydrous microstent. So there was a pretty good treatment effect that we can see with the Hydrous. So the Hydrous microstent is currently only implantable along with cataract surgery in the United States. So insurance will not reimburse you unless you do cataract surgery as well. So the next step in MIGS for these canal-based devices is testing to see whether or not they have any improvement in IOP just as standalone procedures. So this study, the COMPARE study, compared iStent versus Hydrous as standalone surgery without cataract extraction. So at 12 months, the Hydrous demonstrated a greater rate of complete surgical success and reduced medication use as compared to the iStent. And more Hydrous patients were completely off of medication as compared to the iStent. There was secondary glaucoma surgery that was performed on 2 eyes in the iStent group and none in the Hydrous group. So at least based on this study, it looks like the Hydrous might be more effective than the iStent if you're not doing cataract surgery. The next device we'll talk about is the Zen gel stent. So this is a subconjunctival device that's 6 millimeters in length, has an internal diameter of 45 microns. So you can see it's very small compared to a dime, so that's the smallest coin in US currency, and it's much smaller than that, of course. It's composed of gelatin that's derived from the porcine dermis. It's formed into a cylindrical tube and it's cross-linked with glutaraldehyde. Prior to implantation, the stent is hard, but it is bendable, and once it's implanted, the stent hydrates and swells to create a soft, flexible drainage channel that conforms to tissues. And you can see this in the rightmost photo here. This is an anterior segment OCT picture that shows the stent partially in the AC and going into the subconjunctival state. Clearly here it's bent. The stent comes preloaded into a 27-gauge injector, which you see here on the left. Implantation of this device can be either ab interno or ab externo. It can be transconjunctival or with open conjunctiva. It creates a track through the cornea along for flow of aqueous humor from the anterior chamber into the subconjunctival space, which you see here in this first photo labeled A. It can be done as a standalone procedure. So in terms of effectiveness, in this large study out of Texas, Dr. Grover's group found that 76% of patients achieved an IOP reduction of more than 20% at 12 months on the same or fewer medications. So you can see this group had a mean medication of 3.5. So they were on 3 to 4 meds each, and over the 12-month time period, they did achieve some pressure lowering. However, a third of them required needling and 9 of them required a second glaucoma procedure. So this surgery is not perfect. Next, we'll touch on PreserFlow. This is a device that's currently not approved in the US, but should be in the next few months, or should be introduced in the next few months. It's designed for ab external implantation under Tenon's capsule. It's a little bit longer. It's 8.5 millimeters in length. It has a 70 micron lumen, has a wing design to direct the orientation of the device. That doesn't have a plate, so potentially it's less traumatic than a tube shunt surgery. And it's made of a biocompatible material that's a mix between silicone, rubber, and polyurethane. So the large randomized clinical trial of this device is still in the works. We don't have the data for that. We can look quickly at the data for mitomycin C, different doses of mitomycin C with the PreserFlow shunt. And what we see here is so they did, sorry, I can keep going. So they looked at mitomycin C of 0.2 milligrams per ml versus 0.4 milligrams per ml, and it did show pretty effective pressure lowering at either mitomycin C dose. The higher dose of mitomycin C did lead to more IOP lowering, not surprisingly. And in terms of adverse events associated with this, so it's things that you think of with trabeculectomy, so increased IOP, numerical hypotony, keratitis, hyphema, etc. So just to close, the release of the iStent was a groundbreaking change in glaucoma options that are available. We now have many other MIGS devices available. However, we don't really have great long-term studies on any of these devices. So while these may be very exciting and may offer, they may have a niche for various types of glaucoma patients, there still remains to be known whether or not they can provide the long-term benefit that trabeculectomy and tube shunt surgery might be able to do.
Thanks, Dr. Akriti. Before Dr. Ayyala comments on this, is Dr. Nadisha Singh here? Not here. Ma'am, you leaving?
Bag of surgeries that are coming up, and I do believe it will make its presence felt in India too. A lot of these mixed modifications that
everybody. So moving from micro to macro, so I'll be just talking about Ahmed glaucoma wall, not actually the routine technique, but I have a slight modification of that. So I'll be telling you about that. In India, basically, we have two tubes which are mostly done. One is Adi, that is the non-walled, and the walled one is the Ahmed. So just going through the basics, Ahmed wall is composed of silicon tube which is attached to a polypropylene tube plate which is about 184 millimeter square. That is the FP7 model. Then the wall made up of this thin silicon membranes in the anterior portion of the plate that opens and then closes in response to the pressure changes. So inlet is wider than the outlet, which creates a pressure differential. And it has got specially designed trapezoidal chamber to create a Venturi effect to help aqueous flow through the device. So it's based on Bernoulli's equation of hydrodynamic principle. The wall opens at the pressure of about 8 to 10. So when the pressure is going above 10, the wall is supposed to open. And if it goes below 10
Anupam, please don't miss showing us the video. So
Yes,
keep time for that. Just 6 minutes left.
Okay.
So this all, I think most of us know. Just
Yes.
go to the video first.
So I will.
Yeah, go ahead. Yeah, this is fine.
Yeah. So basically, here's the difference. So to cover the tube, what we have got is the three choices. One is the tutoplast. Tutoplast is the pericardial graft, but which is not available in India and it's very expensive. So won't be talking about that. Second is the cornea. Cornea is a very good medium of covering your tube, but the problem again is availability. We have a long waiting list for the corneal grafts to happen, and you can't have an additional waiting list for the glaucoma patients. So that is not even though it is very effective, but not very practical for us. So what we use is the scleral patch, which is the most commonly used medium to cover the tube. Quickly going through the video of the tutoplast. Can I forward this video? It's I'm not getting a line below. Yes, okay. So yes, this is the tutoplast, which is been covered for the tube. So usually this is not available, but I am just showing it so that you know that we have to take some different tissue to cover the tube. So coming to my video, this is what basically I do.
You can take your time here. This is important.
So we need a good conjunctival excision. Usually I do a blunt dissection so that you are not cutting any tissue. I do it with a Westcott's. Go a little deep because your wall really sits deeper. This is, I am doing it in on a superotemporal quadrant. Then I take a scleral flap. Now usually this is about 4 to 5 millimeters in width. I do it with a 15 number or a 11 number blade. This is a actually NVG. This is a neovascular glaucoma. Yeah. So he also has a cataract, but I am doing a glaucoma surgery first.
This is a primary tube, right?
Yes, this is a primary tube. So the beauty of this tube is that you can do this as a primary procedure, and it's really safe and works well. So I make a scleral flap with the help of a 15 number blade, and then I'm also use a crescent. A sharp crescent is used because you need a uniform flap. You need at least a 50% thickness flap, so it's covering well. And most of us who are used to doing SICS surgeries, creating a flap would not be very difficult. The crescent blade is important because instead of doing it with a 15 number blade, do it with crescent, so you get a uniform thickness flap. So once I make a flap, and then I make a small scleral tunnel behind this. So this is about 4 to 5 millimeters, and then I make about 3 millimeter small tunnel behind the flap. So this is again done with the help of a blade and a crescent. This is called as the priming of the wall. So you introduce BSS through the tube, and the wall opens up. You can see the fluid coming out through the other end. So now it is ready to use. So you nicely tuck it inside. Suture it with 80 nylon sutures. Cut the tube so that about 2 to 3 millimeters is inside, and you put through the scleral tunnel, and making an opening in the anterior chamber through a 26 gauge needle. Your opening should be parallel so that your tube is not touching the cornea or the iris. So it should be well in between. So here you will see it's well covered. So the whole 8 millimeter right from the limbus to the plate, it's well covered. And then you suture the flap with the 10-0 nylon sutures, and then cover it with the conjunctiva. So here you need a watertight closure. Yeah. So that's basically the end. So what are the advantages? It's easy to make. Those of us who are doing small incision surgeries, we can easily make this. You're not dependent on any donor graft, so you can just plan whenever you want to. It covers the full length of the tube, so it is safe. I have been doing this for last 7 years, and I have not got a single tube extrusion with this. Flap is strong enough, and no sterility issues, because we have got those scleral patches that we use. Probably they are not stored so well, so the sterility is always an issue for us when you are putting a scleral flap. And then cosmetically this looks much better, because when you are putting a scleral flap, scleral patch, it's very thick, and later on, cosmetically it appears very, you see that white patch in the eye. So this appears much better. Thank you.
Can you show that part again where you make that second flap? Is it can you control the video or it's going to run again?
फॉरवर्ड करना है उसको.
Click on it, click on it. Yeah. Go ahead, yeah. Go ahead. नीचे, 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 नीचे. Click.
आप मत करो, मैं कर रहा हूँ.
Get that bar again.
वो बाहर नहीं आ रहा है उसमें, नीचे फॉरवर्ड करने के लिए.
आप थोड़ा सा आगे क्लिक कर दो.
इधर से जा रहा है वो. हाँ, आगे 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 करो, आगे करो, आगे करो.
नहीं ठीक है, चलने दो फिर. हाँ चलने दो, चलने दो. ठीक है. So Ramesh, while it's
Running again, are you happy with the dimensions of this flap first?
It's more than adequate. First of all, congratulations. Very nice presentation. If I may, I'm much older than you, so
No, I followed him in Tulane and New Orleans. He does tubes left, right, and center. So we are hearing the master.
I've been involved in the tube technology development right from the very beginning. I work very closely with Dr.Ramesh. Some of these modifications are based on my research. So let me comment on this. Stop right there. You should never hold the plate with your 0.12 forceps. We did the original studies where we pointed out that plate is designed to be extremely smooth. And the reason for that is you indent the surface of that with your 0.12 forceps, it's going to attract fibroblasts. So the smoothness will prevent the fibroblasts migrating on top of the plate from hanging on to the plate. You create a dent on the surface, fibroblasts will latch onto it. When there is a hole, fibroblasts latch onto it. There's an indent, fibroblasts latch onto it. Number two, never hold the valve like the way you are holding it because it can crack the rivets. And once the rivet is cracked, then the valve mechanism is gone. So rule number one, don't touch the plate. Rule number two, don't grab the plate as you insert it subconjunctivally across the valve location. The eyelets are located. Grab hold of the plate through the eyelet. That's the safest way for you to handle the plate. That's number one.
Thanks.
Number two, the reason why we use the pericardium or scleral patch graft is this. Silicon has a long memory. Silicon wants to be straight, whereas you curved it now across the curvature of the eyeball to locate into the iris, into the anterior chamber, right? So every time the eye moves, the silicon wants to become straight, and in the process, the micro motions of the eye, it's going to rub against the overlying conjunctiva, resulting conjunctival erosion, and that's where the tube exposure comes. Once the tube is exposed, it's a nidus for bacteria to latch onto, and you'll end up with.
Good welcome, sir. Good afternoon, everybody, and I thank AIOC for this challenging situation over here to defend micropulse laser. So, I have already put a question mark here. So in our busy OPD, we often see cataract and glaucoma together. As recently, I saw this picture with a dense cataract, pressure 35, advanced glaucomatous cup, and I was pretty clear what I am going to plan. But when I saw the other eye with a failed trap, PL denied status, and glaucomatous optic atrophy, I was bound to rethink. So standard options before us when we see this combination is obviously a trabeculectomy followed by phacoemulsification or a phaco trap. We know it very well that there have been inherent problems with trabeculectomy. They can be chamber-related infections, leaks, effusions, or maculopathies, with a failure rate of around 10 to 30%. Now, there can be tricky situations in practice. Eyes like these, when you have a decompensated cornea, a shallow chamber, non-dilating pupil, and a nut hard cataract behind that. Or you see a chronic uveitic case with secondary glaucoma and a dense cataract, pupil non-dilating again. Situation like this, with a dense cataract, trauma, vitreous in AC, dialysis, or a neovascular glaucoma with an indwelling cataract. In these situations, often people do trab, and this might be the result. You may have a failed trab with a cataract in situ again, or cataract with status post keratoplasty and secondary glaucoma. In these situations, trabeculectomy has still higher chances to fail. And then to my rescue often comes this micropulse laser. No financial interest, but yes, it is useful. What it does, not the time permits me, ma'am beautifully expressed in her talk that it enhances the UVS scleral outflow facility, and this has been proven in some histopathological studies. What I do is a small modification giving the best of respect to the gold standard procedure of trabeculectomy, that when we do this micropulse laser at our center, we keep a window of 3 clock hours there, because we have no published data on what amount of scarring this laser is going to give. So even still, if we need a trabeculectomy, we have a window to do that. Our experience has been with silicone oil filled eyes, post-keratoplasty, neovascular glaucomas, and post-keratoplasty issues and failed trabs. What protocol we are following is that we give the maximum medication and then do a micropulse laser, and then after 4 weeks of laser do a phacoemulsification. Then do a weekly follow-up, and what we found that with neovascular glaucoma the results were a bit variable. After a good control of pressure, there were resurgences again because of the confounding factors. Probably if the PRP was inadequate, if there was still hypoxia left, then the pressures again went up, but some of the cases performed well. The best results I got was after failed trab. After phacoemulsification, people gained good vision and the pressure could be maintained nicely with 1 or 2 drugs. After keratoplasty, definitely the results were disappointing, and I found that even after removal of cataract, the pressures again went up, maybe because of developing PSC or something like that. Traumatic cataract patients were happy. We did a toric IOL, we did rings with cataract and pressure controlled after micropulse, and patients were therefore happy. What I conclude is that with micropulse laser, a comprehensive ophthalmologist, mark my words, a comprehensive ophthalmologist can tide over these two combinations together. Complications of trabeculectomy can be averted. Single-eyed patients, they can be dealt with more safety margin. Dense cataracts, you can do SICS, ECC again, and the window modification which I talked about still keeps the door for trabeculectomy open. A very long-term follow-up definitely would be required to advocate what I said, but definitely it is worth thinking once. Thank you.
Mohit, now I'm convinced that you were trained in Singapore, because you work with Paul Chu,
Yeah, for
for some time, and that is why he's a fan of this technique. I'm not against it.
You need nutrition in the eye, and you destroy that, you end up with hypotony and hypotony-related complications. And so I've never been a big fan. Micropulse has it will have its movement in the sun, and then after a while it's going to fade away. But the current technique of application needs to be modified, I think, before it will have some success. I still think doing ab externo canaloplasty to be the most effective procedure for a PKP glaucoma. I've done hundreds of canaloplasties and probably published the most among all my peers on canaloplasty ab externo. One thing I do regret is never publishing on this subgroup of penetrating keratoplasty with glaucoma. I tell you what,